Dr. Kamfwa, who should be joining us in the hub. Unfortunately, I'm not able to join the team. I'm in the field, and I hope my network will be able to hold as we start the session. As always, I would like just to remind us that if we have anything we'd like to contribute and say, let's put it in the chat. And if you want to say anything, you can just raise your hand and we'll be able to pick you. If you're in a very loud place, noisy place, you can put everything in the chat, and then we'll be able to communicate as we go on. So IT, I'm not sure if our team in the hub is ready.
Yes, Dr. Zyambo, we're ready to start.
Okay, thank you very much. So without further ado, I'm going to invite Dr. Kamfwa just to begin to share his slides, introduce himself, and begin to just take us through today's session. Dr. Kamfwa.
Thank you so much, everyone who has joined us on the call. I'm Dr. Kamfwa, a consultant gynecological oncologist based at Cancer Diseases Hospital. At the same time, I'm the cervical cancer focal point person for Ministry of Health. Today's session, like what Dr. Zyambo has talked about, our objective is to explain the cervical cancer basics, then also to describe the epidemiology and public health in Zambia, and to discuss prevention and screening, also to explain HPV vaccination and policy. Dr. Zyambo, over to you for the poll question.
Thank you very much. I think we'll go straight into the poll questions. We will invite our people on the call to just participate. So what are the two most prevalent types of HPV that causes 70% of cervical cancer worldwide? Is it 6 and 11? Is it 11 and 16? Is it 16 and 18? Or is it 6 and 18? Please go ahead and pick which one is the correct answer. Okay, we have a few more seconds before I can end the poll. All right, thank you so much. Allow me to end the poll. So Dr. Kamfwa, looks like we have about 60% think C is the correct answer. So let's see how that goes. You can pick it up.
Thank you so much, Dr. Zyambo. If you look at cervical cancer, it is a public health problem. And when you look at this disease, it's one which we can prevent. It's one which we can even cure as long as we diagnose it quite early. And it's a disease which we can even eliminate. But we wanted first to discuss just a bit of the basics about this disease. When you look at cervical cancer, it is caused by the persistent infection with human papilloma virus. In fact, 99% of cervical cancer causes, and the pre-cancers, it is related to the infection with human papilloma virus. And we should know that human papilloma virus is a sexually transmitted infection, and often it's asymptomatic. Since we said that it's common, it shows that more than 70% of both men and women at some point, they are likely to pick up this HPV virus. And when we look at HPV, we have more than 100 HPV subtypes. And these, we classify them either low risk or high risk. So in case somebody were to ask you, what causes cervical cancer? It is not just every human papilloma virus. It is because of the persistence of high-risk HPV virus. Reason being is that we have got those low risk, such as 6 and 11. These are the ones which can cause genital warts, or they can just cause subclinical HPV infections. Now, when you look at 16 and 18, these two, 16 and 18, they are the ones which cause more than 70% of cervical cancer worldwide. Even in our country, it's 16 and 18. When somebody is talking about 6 and 11, it's those subclinical infections or genital warts. But when they ask you, 70%, it's 16 and 11. And we know HPV does not just cause cancer of the cervix. It can also cause cancer of the anus, cancer of the throat, cancer of the vulva, as well as cancer of the vagina. Over to you, Dr. Zyambo.
Thank you. Thank you. Very enlightening so far. Thank you very much. The next poll question is, how many years does it take for women with weakened immune systems, such as those with untreated HIV infection, to develop cervical cancer following their infection with the human papillomavirus? A very, very interesting question, this one. And you can see the type of answers. Some says 2 years, some says 5 to 10 years, others say 15, 20 years. Okay, we'll just allow people to poll for 10 more seconds. Okay, thank you very much for participating. I'll end the poll. So, Dr. Kamfwa, most people think it's within 2 years. Let's see how this presentation will go. Please pick it up, Dr. Kamfwa.
Thank you so much for those responses. So let's establish one thing. First of all, when you look at cervical cancer, what that illustration in front of your screen is showing you is a low progression of cervical precancer to cervical cancer, meaning that we have got a window of up to 10 years or more to detect and treat pre-cancer lesions and prevent their progression to invasive cancer. When you look at what happens, first, the HPV is going to infect the cells which are slightly above the basal membrane. And this is going to take some weeks for viral replication to occur. And normally what happens is that about 80%, this is going to occur in regression. So in those who are immune competent, those who have got very good immunity, on the average, it is going to take about 15 to 20 years for those abnormal cells to become cancer. Remember, we said that 80% of those HPV infections are going to regress. It means it's just about 0.8 to about 1%, or to about 10% that is going to develop into cancer. But take note, for those with weakened immune system, such as those with untreated HIV, it takes 5 to 10 years. It cannot take 1 to 2 years. If it was taking 1 to 2 years, we were going to be having a lot of women developing cervical cancer, those who have got weakened immune system. But it takes on the average about 5 to 10 years. So within 5 to 10 years, we still have this window of opportunity for us to screen the women who are HIV positive. So when you look again at that illustration, it is trying to tell you what normally happens with HPV infection. When the cervix has been infected, there are a couple of things which can happen. They can either be clearance of the HPV virus, and it normally takes about 2 years if somebody has got very competent immune system. If the HPV infection is not cleared, then what will happen is that it is going to progress to pre-cancer. But even if there is progression to pre-cancer, there is still an element of regression. And like what we mentioned, after there is this progression of pre-cancer, about 10% will progress into the picture which we are seeing in the picture collage, which is at the far right, in which we now have cervical cancer. And if you look at the schema for the unstable cervical epithelium, what normally happens is that when that cervix has been infected, it has to depend whether it's CIN1, CIN2, or CIN3. All those are going to go into either regression, to go into persistence, or to go into progression. So it takes slightly about 5 to 10 years for our women who have got weakened immune system to develop cervical cancer. But for the general population, it takes about 10 to 25 years, that period. So what have we established? We have established that when HPV infects the cervix, what is going to happen is that the woman may not even be feeling anything. She's going to be asymptomatic. But by the time she starts having those symptoms, it shows that it is reaching an advanced state. And normally the symptoms that the woman is going to present with, we normally say it's abnormal perivaginal bleeding. Why do we say abnormal perivaginal bleeding? It's because every woman within that reproductive age group, we know that she's going to be having those menses. But when she starts having irregular menstrual bleeding, especially bleeding in between the periods, or bleeding after having sex, or bleeding when she has attained menopause, then it becomes a problem. Sometimes the woman is just going to be complaining of pain in the pelvis, or she's going to have constitutional symptoms. And sometimes she's going to present with abnormal vaginal discharge. And when it is so severe, the woman might present with vesicovaginal fistula or rectovaginal fistula, or she can come with severe anemia or renal failure. Dr. Zyambo, over to you.
Thank you so much, Dr. Kamfwa. I see we can see them very, very clear, the answers to the 4 questions that we've been having so far. The next 4 question is, what is the incidence of cervical cancer in Zambia? What is the incidence of cervical cancer in Zambia? Is it A, 49.4 per 10,000, 49.4 per 100,000? Is it 71.5 per 10,000, 71.5 per 100,000? Yeah, these numbers, Dr. Kamfwa, they have confused everyone.
I know, and I'll clarify.
Yeah. But we do know that cancer is one of the cancers that cervical cancer affecting our women in our population, commonest cancers. Okay, so just a few more seconds and then we'll end the poll. Okay, great. So allow me to end the poll. So, Dr. Kamfwa, we have B as the most selected here. That's 49.4 per 100,000. But we do think that some think it's A, some think it's D. Let's see what you have for us.
Thank you so much, Dr. Zyambo. Colleagues, don't get confused. So let me set the stage this way. When we are talking about incidence and mortality for cancers, it's out of 100,000. So whatever you are talking about cancers, whether it's mortality or incidence, it's out of 100,000. Not 1,000, not 10,000, but out of 100,000. So when you look at cervical cancer, first of all, in 2022, we recorded about 3,640 cases. And out of that, 2,285 died. The only ones who managed to be seen at Cancer Diseases Hospital, out of those 3,640, were only about 800. So when we look at the incidence for cervical cancer in Zambia, currently it stands at 71.5 in 100,000 women. So in other words, when there are 100,000 women, at least 72 of them are going to have cervical cancer. The mortality is the one which stands at 49.4, again, out of 100,000 women. So remember, the incidence is higher than the mortality. So again, in 100,000 women, there are about 49 women who die. But let's talk about those with HIV, the ones living with HIV. Remember, that is our concentration even when it comes to screening. It's because those women who are living with HIV/AIDS, they are 5 to 6 times at risk of developing cervical cancer. 5 to 6 times. If you forget, sometimes they ask you the question, what is the risk of those with the HIV to develop cervical cancer? Just raise your hand, 5 fingers. They are about 5 to 6 times at risk. So for incidence, 71 out of 100. For mortality, 49 out of 100,000. Over to you, Dr. Zyambo.
Thank you very much. Very, very clear from that feedback, Dr. Kamfwa. The next 4 questions, we would like you to really engage with us. And this one is, what is the current recommendation by WHO as a primary screening test and treatment approaches among both general population of women and women living with HIV? How do we screen? A, VIA and VILI. B, cytology. C, colposcopy. D, HPV DNA. Which one is the current recommendation by WHO as a primary screening test and treatment approaches among both the general population of women and those living with HIV? Thank you so much. Already we are polling and picking which one is the best answer. Thank you so much. I'll allow you some extra 10 minutes. Okay, thank you very much. I can end the poll here. So, Dr. Kamfwa, we have got two favorite options today. We've got A and D. I'll stop sharing and Dr. Kamfwa, you can pick it up.
Thank you so much again for those responses. Let me make a very quick statement here. For a long, long time, especially lower middle income countries, they have been using VIA, which stands for visual inspection with acetic acid, and VILI, which stands for visual inspection with Lugos iodine. These were being used for screening, especially in the lower middle income countries. But currently, according to WHO, it has made recommendations that both the general public and those who are living with HIV/AIDS, they should be screened with a high performance test, And this high performance test is HPV DNA. The high performance test is HPV DNA. So the current recommendation by WHO is to screen women with a high performance test, which is HPV DNA. If you look at our country, we started screening in 2006, and from inception, we have been using VIA. But starting from 2021, we started moving slowly at 10%, now screening with HPV DNA in line with what recommendation from WHO. If you look at that in front of your screen, it is showing you that WHO strategy to eliminate cervical cancer. Please focus on the middle number, or I mean the middle percentage, which is talking about 70%. WHO states that 70% of women should be screened with an HPV test at least at 35 years and 45 years of age. And when we do this, the target is 30% reduction in mortality from cervical cancer. We want a screening test which is high specific and at the same time highly sensitive. And this is why we need HPV DNA. So when you look at, again, in front of your screen, it is showing you various screening tests which are available. We have got the HPV testing, we have got cytology, and we have got VIA. In Zambia, when you look at VIA, like what I mentioned, it is the common one which is used. And as at now, it is about 60%. But we are moving towards HPV DNA, which is now at about 30 to 40%. And cytology is mostly in the private sector. So when you look at the options which are there, first of all, it's about the strengths and the limitations that are needed to be taken into consideration in as far as coming up with a policy of screening, the planning and implementation is concerned. So whatever has been shown there, regardless of the screening test which has been used, the focus is to maximize the coverage. But how can we maximize the coverage? We can only maximize the coverage if we go the route of HPV DNA. Reason being is that for HPV DNA, we can even do self-sampling. The woman does not every time require to be sampled by the health provider. She can sample her cervical vaginal fluid and take them to the lab and the test can be done. So for us as a country to increase the screening coverage, that's the reason why we have gone that route. And that's why WHO has adopted that route. Dr. Zyambo, over to you.
Thank you very much. I think that's a very good explanation there, helping us understand why there's this approach. I've seen some questions in the chat. I hope we can understand why this is like this. And so the next question is on HPV vaccination is part of primary prevention of cervical cancer, A, B, secondary prevention of cervical cancer, C, tertiary prevention of cervical cancer. Please do take part and pick an answer from those. Okay, 10 more seconds. Okay, thank you very much. I'll end the call. Dr. Kamfwa, please pick it up.
Thank you so much for those overwhelming responses. First, let me just quickly talk about, again, primary prevention, secondary prevention, and tertiary prevention. Even at the outset, I talked about them. When we are talking about primary prevention, this is where we want to prevent HPV infection. And when we are talking about secondary prevention, this is where we find that somebody already has got HPV, and it could be that HPV has caused the pre-cancer, but we don't want that pre-cancer to go into cancer. Then it becomes the secondary prevention. So secondary prevention, we use screening. Primary prevention, we use vaccination. Then tertiary prevention is where we have to diagnose a woman saying, well, this woman has got cancer, but we should treat and manage cancer. Then that becomes secondary prevention. So how have we been faring? If you look at your screen, you find that the target population is the girls who are aged between 9 to 14 years old. And how have we been giving them the vaccines? We have been giving them the vaccines at the health facility or in the community or in the schools. And what have we been doing? We have been giving now 1 dose HPV regimen. And I'm going to explain how this is being done. And there was what we call multi-age cohort vaccination. Remember, when we started giving HPV vaccine, we were giving only to those who were 14 years, the first dose. By the time they go into 15 years old, we give them another dose. So that was like a single cohort. But that was being done, reason being we didn't have enough vaccine. From last year, which was September, what was instituted was multi-age. Multi-age, meaning that we had to move from that single cohort age into the age starting from 9 to 14. And I'll try to explain much about that. What has been happening is that we have been giving this HPV vaccine, and the strategy is during the single week campaign. And it has been integrated in the Child Health Week services. If you have paid attention, whenever we are having Child Health Week, slightly at the end, there is an announcement which says, and all the girls aged between 9 to 14, we shall be giving them the HPV vaccine. When you look at just HPV vaccine as a primary prevention, it can prevent more than 90% of cervical cancer. And of course, The coordination in as far as the vaccine is concerned has been with the Ministry of Education and also the management teams at private schools, and also involving the Parent Teachers Association. For community outreach, remember there are those girls who are out of school. This is coordinated through CBVs and also through community mobilizers who also help as gatekeepers. So somebody is going to ask, saying, how about those who are immune incompetent, our girls who are living with HIV? Remember, these ones, we give them 2 to 3 doses. In fact, for us as Zambia, we have remained with 3 doses for those who are immune incompetent. But for these who are immune competent, we have moved from 2 doses to just a single dose. And we have got more than 6 HPV vaccines which are available. When you look at these HPV vaccines, they protect against 16 and 18. Remember what we said, 16 and 18 is what causes more than 70% of cervical cancer. And when you look at this vaccine, it's very safe, very effective, and it can prevent HPV infection and cervical cancer. And please, please, the vaccine is given as 1 dose, and this 1 dose has helped us increase the vaccination coverage. Reason being is that 1 dose is less costly, less resource intensive, and it's even easier to administer. How have we fared? Remember what I mentioned saying in 2013 September, what we did was to institute multi-age cohort vaccination. And during that time, we targeted the 9 to 14 years old, and we were giving them that single dose schedule. So, what have we learned today? We have come to appreciate the fact that cervical cancer, despite it being a very preventable disease, why is it preventable? It's because we know the tools that work, and those tools are within our reach. But we have come to realize the fact that it is the most common cancer in Zambia, and it is a public health problem. But this public health problem, we can still tackle it. How can we tackle it? Through 3 preventive measures: primary prevention, secondary prevention, and tertiary prevention. What else have we appreciated? We have appreciated the fact that what causes cervical cancer is persistent infection with human papilloma virus. And it is 16 and 18, which causes 70% of cervical cancer. And we have come to appreciate that those who are living with HIV/AIDS are 5 to 6 times more at risk of developing cervical cancer. That's why you find that in almost all the clinics, we have integrated cervical cancer into the HIV services. And we have again come to appreciate the fact that cervical cancer can be cured as long as we discover it and diagnose it at the early stage, and we treat it promptly. Then we have also come to appreciate the fact that prophylactic vaccination against HPV can prevent cervical cancer at most 90%. And what is required is also screening and treatment of precancer lesions. These are very effective strategies to prevent cervical cancer. Over to you, Dr. Zyambo. Oh, sorry. Dr. Zyambo.
Yes, Doc.
Yes.
Thank you. Thank you so much. Very informative. I can see a lot of people in the chat are quite impressed with the presentation. Very up-to-date information. And I would really appreciate your time that you've put in together.
Just a minute, did you
this.
want me to run through the 4 questions, the answers? I've seen they have highlighted them.
Yes, we can run through each one of them one by one.
So the first question was, what are the 2 most prevalent types of HPV that causes 70% of cervical cancer worldwide? We said that it's 16 and 18, which causes 70%. Where there is 6 and 11, please, that causes just subclinical infection or warts. Then the second one was how many years does it take for women with weakened immune system, such as those with untreated HIV infection? Remember, those untreated HIV infection, it means we haven't even put them on ART. So it takes just about 5 to 10 years. Please, it cannot take 1 to 2 years. 1 to 2 years, it won't happen. So because of 5 to 10 years, this is why we want you to quickly screen those who are HIV positive, as compared to the general population where it takes 15 to 20 years. Again, we talked about the incidence of cervical cancer. We said all the cancers, remember the incidence and mortality, it has to be out of 100,000. And we said it's 71.5 in 100,000. When you talk about 49.4, that is mortality. And of course, we talked about the recommendation by WHO. We said that this is supposed to be screened with HPV DNA, not visual inspection with acetic acid. And the last one was HPV vaccination is part of the primary prevention. Why did we say it's part of the primary prevention? It's because we don't want any girl to have HPV infection. So those were my references. Over to you, Dr. Zyambo.
Excellent. Thank you very much, Dr. Kamfwa. So at this point, we'll invite comments, questions from the network. If you have any questions, please raise your hand, and then we can allow you to ask a comment. Meanwhile, as we do so, please go to the chat and complete that feedback form. We really will be happy to hear from you on this feedback. Martin Mamba. Martin, is it from Mamba? Please unmute yourself and please go ahead and unmute. You will be able, I think we've helped to.
Yes, Doctor. Good afternoon, Dr. Zyambo. Thank you very much, Dr. Kamfwa. I hope I'm audible.
Loud and clear.
All right, thank you. Thank you so much. Very interesting topic. I just have a concern. My concern is looking at the statistics, where the prevalence for cervical cancer is very high as compared to the target given by WHO of 4 out of 100,000. So a small analysis that I've done personally, looking at the rise of cervical cancer disease in some part of the country, more especially in rural provinces. So the analysis is attributing this rise to 2 factors. One would be the quality of screening, where maybe probably we are missing out some cases which were supposed to be detected early. And two, it could be that awareness is not as at the expected, at the level that we expect. I know there's a good number of activities that are being done in order to raise awareness among general population. But my curiosity is that we still receive, like where I'm living in Western Province, we still receive a lot of cervical cancer disease, which is attributed to late presentation of patients at the facilities. And this is knowing that most of the facilities are screening for cervical cancer, but we still have that rise in terms of cases that are reaching where little can be done at the facility. So I don't know if MOH as a program maybe strengthening awareness in the general population in order for us to curb this late presentation of patients coming to the facility when the disease is already advanced. I don't know if there is such a program looking at the number of cases where we are living, it could be more than 72% that has been presented, because looking at the number of patients that has been screened, let's say from 2021 to 2023, we have a lot of cases as compared to 100,000 women who could have been seen. So I don't know if my question is clear. Thank you so much, Dr. Kamfwa.
Thank you so much. Very good question. Dr. Kamfwa, just hold on. Let's listen to Maureen. Maureen, please unmute and you can ask your question.
Good afternoon, Dr. Kamfwa. A very good presentation, and moderator Dr. Zyambo. My contribution or question is over the same HPV PCR test we are doing. Most of the women shun the speculum. So with the PCR we have, we need to have the speculum for us to do the same PCR test. Unlike when we're doing the Evelyn test, which was easier and almost all the centers can do that, then we subject the VIA to those which are positive. So I would ask or plead from our sponsors or those aiding in finances, if they could go back to the Evelyn brush, which was better because it will cover a bigger area than those which have the speculum to do the PCR, which has come now. And I agree with the previous speaker, if there are any other activities planned to widen the sensitization so that people can understand, because we are having challenges on the ground to make these women come for screening. Even if you give IEC, you try to make them understand, it is very difficult because we all know they are not sick, but they are saying you are forcing us as if you want us to get sick. So the message is not yet fully understood out there. So we need more reinforcement as we do it on the ground. It is covered even from up there. Thank you.
Very interesting questions and comments, Dr. Paul. Please respond to those.
Thank you so much, Dr. Zyambo. If the experts are not on the call, then I'll quickly take it up. I wanted maybe also the experts, if they can contribute. If not, then I can take it up. Dr. Zyambo.
No, actually, that will be very, very important. If we have any of our experts on the call, please do come in and give your advice, guidance on this. Thank you.
There are a lot. There is Dr. Chisele, Professor Mwanahamuntu, Dr. Fundafunda, Dr. Christian, Dr.
I was looking for them.
Munalula, Makatimui. Are they not around?
Okay. Then it's okay. I can give you a 50.
I can't find them. Dr. Chisele, are you on? No, I don't think so.
Okay. If none of those, even if none of those is around, let me address the two.
Dr. Siamalambwa is here.
Okay, yes, you can go ahead.
Dr. Siamalambwa.
Yeah, thank you very much, Dr. Zyambo. I didn't get some of the questions. My network was low.
So really, the questions were around, I think it's something to do with the speculums for use of when collecting samples, and also strategies on improving uptake for the SEM, for cervical screening, and the challenges. Yeah.
Okay, I'll talk about something to do with speculums. Yes, most of the women dread the speculum examination. They don't like it. So HPV test, especially the one where the woman collects the specimen herself, reduces the number of women that have speculum examination. Remember, when you test women using HPV, you expect about maybe 10 to 30% of them to test positive. For those that test positive, they'll still need to undergo speculum examination, since you would have found the problem, you would have found that they have that virus that actually causes cervical cancer. But however, the number will be reduced, and even the healthcare staff have to do speculum examination, because they're the ones that have to do it. They are freed up, since women are able to collect the specimens by themselves. They are freed up to do or to offer other healthcare services. So that's one of the advantages of using HPV testing, especially self-sampling. Beyond it being the most accurate. Anyway, yeah. The other component, Dr. Zyambo, in terms of creating awareness, I've seen on the call, we're about 415 of us. It's our responsibility. In fact, what we are doing now is part of the things we're supposed to be doing to make the women aware that these screening methods that are available for us to screen them for cervical cancer. If each one of us actually can talk to 3-5 women, that awareness would be good enough, beyond the other methods that we can actually use, like the ones our friends in health promotions use, such as going on the radio, going on, or in general, going on the media, talk about cervical cancer, and even using posters in our, for example, in OPD, you can use posters to create awareness. I can talk throughout, Dr. Zyambo, but I think I can stop here. Thank you.
Thank you so much.
Just a quick contribution, Dr. Zyambo, to what
sure, go ahead.
Dr. Siamalambwa has mentioned. And I appreciate both questions. First of all, I think what we require is to heighten the awareness, the advocacy, and even the social mobilization. Why have I said this? Reason being is that when you look at the model which we have adopted, it is more of opportunistic population-based screening, in that those who are HIV negative, they are not attracted or they are not reached out in as far as screening is concerned. much of the screening which we talk about here, it's for those who are HIV positive. This is where we find what might be labeled as organized national population type of screening, as opposed to opportunistic in the general population. Now, when you look at the HIV positive, within that reproductive age group, they only represent about 11.3%, meaning that the 89% are HIV negative. When you look at WHO, that 70%, colleagues, if you paid attention, it did not say those who are living with HIV/AIDS or those with the general population. It just mentioned saying women. So meaning that even us, we are supposed to go outright to screen those. The entry point should not just be the HIV clinic. Everywhere where we are, such as the OPD, men's clinic, the sexual reproductive health clinic, the MCH, all these should be entry points. And we need just to heighten that mobilization, especially in the community. Dr. Siamalambwa has mentioned there are 415 of us. It's up to us to go out. Then the second thing, I appreciate the thought that we have been using, VIA, to tell you we have come to realize that even if we were screening with this VIA, some of these women that we labeled saying they were VIA negative, they are the ones who are coming now with invasive cancer, and who have been having this problem. So the type of screening method which we have been using previously has also contributed to this. And another contribution why we are even seeing a high number, it's because we are doing more, we are finding more of these women, and our data is now up to date. Then there was that issue of the speculum. Again, with regard to the speculum, we are trying to run away from it by advocating the self-sampling. In the self-sampling, particularly when we are using even the gene expert, there is no use of the speculum. The woman only uses the brush to sample the vaginal cervical fluid. Thank you so much.
Well illustrated, Doc. I'll get back to the hands again. We've got Jackson Mweo. You can make a comment, then Franco, then Dr. Muna, and back to Maureen. So in that order, Jackson, Franco, Dr. Muna. Are you able to unmute Dr. Jackson? Okay, Franco, you can pick it up.
All right, thank you very much, the doc, and thank you very much for the presentation that I've gone. My question is just on the lab aspect, in addition to other questions that have been asked, which I believe the doc has touched, I think, most of them. So for me, it's the quality assurance on the quality of the sample that these women collect by themselves. As because my special area also is on the cytology. So basically, for women that have passed menopause, anatomically, the endocervical part gets to shrink a bit, which, if at all, the quality assurance of collecting of these samples not well checked, I think can also be a contributing factor in having the negative to this group of people, and thereby also having these same people coming with advanced cancer. So I don't know how we can address to this so that at the end of the day, we have the quality sample that is sampled to be tested for HPV PCR test. So that is on the lab aspect, because basically we deal with these things, and I would want us to take keen interest to make sure that we are not missing this aspect. Thank you very much.
Thank you. Jackson, are you back?
Thank you very much, Chair. I was having some internet challenges. I wanted to find out, as Dr. Zyambo indicated, that actually the strand that causes cervical cancer is 16 and 18 count for 70%. However, we are seeing, especially for the brushes, we are seeing the high positivity rate for the other HPVs. Like we received last week, we received just one facility, we received 4 samples. That's HPV. One was negative, but the 3, one was positive for strand 18 and 16. But we realized that 3 of them actually, they were positive for other HPVs. So I wanted to find out what's the virulence of these other HPV viruses, and what is being done maybe to have another vaccine that can counter this, because we're looking at the 30%. It's also a big number. I wanted a comment from the expert. I submit, Chair.
Thank you very much. Dr. Muna?
Good afternoon.
Afternoon, thank you.
Thank you. So this is Dr. Mwansa. I wanted to find out patients who come back, for instance, maybe you do a lip, send the sample and it comes out as CIN3. Right. Then you remove whatever was the problem, and hopefully you've removed the disease cervix. Then afterwards, the patient comes back with the similar problems, and when you test for or other things, you find that actually the patient has advanced to being cervical cancer. So I want to find out for patients who come with CIN3, because we know this one can actually lead to cancer very quickly. What is the proper management? Sorry for taking the presenter back, but in cases like in my facility, we have so many patients of that, and then they end up having cervical cancer, in spite of them maybe having had lip at some point. Thank you.
Thank you so much. We'll get back to you, Dr. Kamfwa, Dr. Siamalambwa. Your comments are welcome.
Thank you so much. I'll answer the questions in the order that they came. First, there was a concern for the quality of the sample for the women who do the self-sampling. Unlike in cytology, remember that's why from the laboratory perspective, he had to say the endocervical portion. So when we are taking the sample for HPV, the brush does not have to go into the endocervical portion. The brush needs only to go into the vagina and just reaching the cervix. That's why even the sample we say vaginal-cervical sample, no need of going into the endocervical. And what has been found, both literature and even here in Zambia, is that when you are talking about a woman who has sampled herself and where the sampling has been done by the health provider, the results is equivalent. So there is no like a compromise in as far as the quality is concerned. I know he was trying to bring the issue of endocervical, especially with regard to what normally happens in as far as cytology is concerned. Then there was another question which was talking about other types. So what has been happening is that for sure, we have started receiving the other types. And most of these other types are the ones which are in the 30 series. The 31, 33, 35, plus maybe 45, and we have got the 52, 58. So these, when we started the program, we wanted to be genotyping just 10% of this. Now, the agreement is that even if it's the other type, treatment has to be instituted. But as at now, we haven't finished the genotyping so that we know and we attribute what is the percentage that the other types have been contributing to us. But when it comes to vaccine, again, let me make note of this. When you look at the 6 types of vaccine which I mentioned, first of all, when we look at one which we have been administering, which is Gardasil, it is a quadrivalent. And there is one where it's quadrivalent in the sense that it prevents 4 types, 6, 11, 16, and 18. Then we have got another one which is a nonavariant. Again, it's Gardasil. It is sometimes labeled as Gardasil 9. Gardasil 9 is a nonavariant, meaning that it's able to prevent 9 subtypes. And 9 subtypes are the ones where we have those which are in the 30 series, and we go into the 40 and 50. So meaning that at the time that we are going to find that there are a lot of patients who are coming out with these other subtypes, during that time, we are likely going to move from the quadrivalent to a nonavalent. But what we have been administering is a quadrivalent, which is doing very, very well. Then I come to the last one, which the doc talked about, CIN3. Please, the management for CIN3, which is pre-cancer, is LEAP. And when it comes to LEAP, one of the things that we want to see on the histopathology is that the entire transformation zone has been removed. Then this is completely excised. 2 things that we want: the entire transformation zone and completely excised. If these statements are not appearing on the histopathology, get back to the histopathologist and you discuss with the histopathologist. The reason being is that if it is incompletely excised or there is part of the transformation zone which has remained, the likelihood is that this woman, we don't know the phase in which this CIN3 is. There is a likelihood that she may come with the invasive cancer. So you asked about the management. The management for CIN3 is LEAP. But if it becomes persistent CIN3 is where we have done, say, 3 LEAPs, and there is no cervical tissue which we have remained. And in that case, if the woman has completed childbearing, then this is when you should do hysterectomy. So the answer, management for CIN3, LEAP. You can even do 2 LEAPs. But if it persists in this case where you have got 3 LEAPs you have done and still giving you CIN3, then offer the woman hysterectomy. Thank you so much.
Yeah, I don't know.
I'm seeing a clinic here. Dr. Siamalambwa, you wanted to make a comment?
Yes, I just want to add on, but I'll try to be specific.
Sure.
On the last question that Dr. Muna was asking, where you do LEAP, it comes out CIN3. So like Dr. Kamfwa mentioned, you need to pay attention to the histology report. If the histology report says In fact, there are two margins that the storage report will talk about. We talk about the margins on the ectocervix, and it also talk about the margins on the endocervix. For you to conclude that the leap that you did was the curative, both margins need to come out negative. I'm saying so because in our environment, we've been doing VIA. When you do VIA, more or less like you are doing it blindly. You don't have a histological report. You don't know how the cells are. The assumption is that you have CIN. So when the result comes out positive, please, you need to pay attention to the margins for you to conclude that you have treated. If you don't pay attention to the margins, if the margins are positive, do not get surprised if the woman comes back with, invasive cervical cancer. Yeah. Then the other point I wanted to add on Dr. Kamfwa and Dr. Khozya was the question that Franco was asking. Even talked about postmenopausal women, and I think Dr. Kamfwa tackled it adequately. I was thinking that there was a bit of confusion maybe with VIA and pap smear. For example, in a postmenopausal woman, you are doing a pap smear, you would want to use an endocervical brush, which is very different with HPV, where you don't need to go into the endocervix. You are doing VIA, for example, somebody is a postmenopausal woman, you can't see the whole squamous junction. In that patient, it means that part of the transformation zone is inside the endocervix. So you cannot rely on VIA to say this one is a VIA positive. That's where maybe you cannot even do HPV. You need to go for a pap smear where you get the endocervical squams. I submit. Thank you.
Very informative. Thank you, sir. Dr. Irene Walia, you raised quite some valuable comments in the chat. I don't know whether you would like to vocalize them or I can read them. You say here that what is the target age for group for HPV DNA screening? Above 30 years, I am worried that if we screen very young girls with HPV, most of them will clear it within a few years. We may get more false positive, looking at a pathology of biopsies, specimens that other subtypes cause cervix in Zambia. So that's a comment from, and a question from Dr. Irene Walia. I don't know if any of the consultants can pick it up.
If Dr. Siamalambwa doesn't pick it up, I can quickly go, unless he wants to go ahead.
Okay, I can go first, Dr. Kamfwa, then you can pick after me. Yeah, I think Dr. Irene Walia, in her points, she's very, very right. You do not want to start screening young girls who are sexually active with the HPV test, because the majority of them will come out positive, when we have actually talked about them having capacity to clear the HPV. So economically, from the public health point of view, it's not worth it to do the testing in the young ones. So in the general population, our target age group is 25 to 49, because those are the women who are at the highest risk of developing cervical cancer. They're still sexually active. If they got exposed when they were still young and the HPV infection was persistent, by then maybe they might have started developing problems. However, in those women that are living with HIV, sometimes you might want to start doing HPV testing much earlier. Like we said, for them, progression of the disease is much faster. From infection to invasive disease, we talked about 5 to 15 years, to 10 years. Like on average in Zambia, girls start having sex around the age of 15. So if you add 15, you add 5 to 15, that's 20. That's why we are emphasizing that you want to start screening the HIV positive girls who are sexually active much earlier. But in the general population, our target age group remains 25 to 49. I submit you can add on, Dr. Kamfwa.
I think you have tackled most of the salient points.
Thank you so much. A question from Mumpundu and Jonathan, in that order.
Good afternoon, network, and good afternoon, Doc. Thank you for the powerful presentation. I just wanted to know the role of voluntary medical male circumcision in the prevention of cervical cancer. Thank you so much.
Jonathan. Jonathan, any comment? Okay. Conrad?
Dr. Siamalambwa, then I can go ahead. Dr. Siamalambwa.
Okay, thank you again, Dr. Kamfwa. I'll start with the question that I saw, an interesting one that I saw in the chat box, talking about postmenopausal women. I think the question is about is pap smear available? So what I'll tell you that in our public health sector system, we have not been using pap smear, we've been using VIA. And VIA for postmenopausal women whose from columnar junction has actually gone into the endocervical canal. You need to do a pap smear, but that has not been available. And thank God now we have HPV testing. So if you test a woman, even if she's postmenopausal, for postmenopausal women, those who are in their 50s, their 60s, you can only test them once. They come out negative, you forget about it. There are safe chances of them ending up with cervical cancer are very, very low. But if they test positive for human papilloma virus, you need to treat them. And there's a way that we treat them. I wouldn't go into detail because okay, I'll mention there's a way we actually do lip. Whether there's a lesion, there's no lesion, we go ahead to do a lip using a pre-excision. I won't go into detail to talk about that. It's HPV. HPV, the test positive, according to our new guidelines, you treat. Okay. Then I'll come back to the role of, is there a role of male circumcision in prevention of cervical cancer acquisition? Yes. The answer is a big yes. We are encouraging men to go for male circumcision. When they go for male circumcision, we know very well that that foreskin will not be there. Because if the foreskin is there, usually there's that moisture. Where there's moisture, infection tends to thrive there. So if there's no foreskin, chances of them even getting infected with human papillomavirus reduce. If it reduces, then automatically them transmitting the human papillomavirus to their partners reduces as well. Over, Chair.
Sorry about that interruption. Otherwise, thank you so much, Dr. Quagy.
Can I also make a,
Doctor?
yes?
Yes, Dr. Kamfwa.
Can I also make a quick statement? Thank you so much, Doc, for that question. Again, one thing that we need to appreciate is that while HPV infection is necessary to cause cervical cancer, it is not sufficient. It is necessary, but it is not sufficient, meaning that there should be some correlates. And when we look at the correlates, particularly when we focus on primary prevention, one of the things that has been studied extensively as a means of preventing cervical cancer is vaccination. Just vaccination itself is going to prevent more than 90% of cervical cancer. So these are the correlates which are going to come, such as condom use, VMMC. These are lower as compared to what we are supposed to advocate. So for our country, in as far as we are concerned, much of the advocacy or the weight should be towards vaccination, because it has proven that just vaccination, all these countries like Australia, which are at the verge of reaching the elimination levels, which is less than 4, it's because they have been vaccinating the girls.
Thank you so much, Doctor. One last question from the chat. Ruth Mwansa is asking, my question is on the HPV DNA. When the results come out positive, let's say 16 and 18, the high risk, then we substitute them to VIA, and VIA, I suppose this is subject them to VIA, and VIA is negative. What's the way forward? I'm very much behind on this one. Ugandans will be highly appreciated. And I think the response here was that let's refer to the guidelines. Maybe you could respond quickly to that one.
So just a quick response. When VIA is positive, or when HPV is positive, and we use VIA, which is the VAT, like what we want to know is what type of treatment should we institute? Should we freeze, or should we burn, or should we excise that part of the cervix? So in other words, when VIA is positive, the woman requires treatment. What type of treatment is going to be instituted? The VIA will just help us, whether we just have to burn that part of the cervix or to excise that part of the cervix.
Thank you so much. I think we could go on and on, but we do appreciate your very overwhelming participation, colleagues. And thank you very much for those responses from Jen. Been very helpful in responding to the chat. And thank you for all those that are posting in the chat. We really appreciate, we've made this session very interesting. So Dr. Kamfwa, any last remarks before we close?
The last remarks is, colleagues, we need to heighten the awareness, the advocacy and social mobilization so that a lot of our women, both those who are living with HIV and the general population, are attracted to screening. Secondly, we need to encourage our girls to go for vaccination. If we do screening and vaccination, just these two will prevent more than 95% of cervical cancer in future. Thank you.
Thank you so much, Dr. Kamfwa. Dr. Quagy, Siamalambwa, we really appreciate your insight during this session. And all those that made their comments, thank you very much. We will see you next week for another session. Have a good day.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you very much.
Thank you so much. Thank you. Thank you.